Imagine surviving, a brutal life-saving bone marrow transplant. You beat the underlying disease, which is incredible, but then your brand new immune system wakes up, looks around, and declares war on your own body.
Yeah, it's a devastating paradox for these patients. I mean, they survived the systemic threat, right? But then their daily quality of life is just heavily compromised by this new battle.
Right, which is chronic graft versus host disease, or CGVHD. And when that immune assault targets the vaginal epithelium, resulting secondary dryness and friction pain, it can be absolutely paralyzing for the patient.
Paralyzing is exactly the word. It's a localized attack on the most intimate tissues, and it completely alters how they live.
Which is exactly why we are taking you into this source material today. We're doing a deep dive into the clinical efficacy of intimate exosomes as a localized treatment for this agonizing side effect of CGVHD.
Because if you look at the Billingham criteria in these papers, we see the perfect storm required for this to happen. The patient receives an immunocompetent graft. The recipient is immunologically distinct from the donor, and, well, the recipient is too immunocompromised to destroy those foreign cells.
Okay, let's unpack this.
Yeah.
Because the donor cells essentially perceive your mucosal tissues as hostile invaders.
Exactly. And that triggers this relentless inflammatory cascade. Over time, that chronic inflammation drives profound fibrosis and sclerosis in the tissue.
So the vaginal and vulvar mucosa undergoes severe thinning. It loses its natural elasticity and basically its entire barrier function.
Yeah, the sources outline the dyspareunia, the friction pain resulting from this, as extreme. The tissue is so fragile. I mean, it's lost its protective cushion and intrinsic lubrication. Any friction causes agonizing pain.
But what really stands out to me in these clinical protocols is the glaring limitation of the standard first-line treatment. Systemic glucocorticoids, basically steroids, are universally prescribed to suppress that overactive donor immune system.
Right. Systemic steroids are necessary to calm that global immune storm, but they present a massive clinical gap. Prolonged use carries severe systemic toxicity.
Which nobody wants to deal with on top of everything else.
Exactly. And roughly 50% of these patients eventually develop steroid refractoriness. The drugs just stop working.
Leaving the patient exposed to both the side effects of the steroids and the active CGVHD pathology. It's awful. But wait, let me challenge the premise of the alternative here, though.
Sure, go ahead.
If CGVHD is fundamentally a systemic immune system rejection, donor cells attacking the host globally, why are we focusing on a localized topical regenerative treatment like intimate exosomes?
I mean, the logic seems slightly backward. Shouldn't we be entirely focused on fixing the global immune response rather than applying, localized patches?
Well, looking at it purely as a systemic issue kind of ignores the mechanical reality of the tissue damage. I mean, systemic immunomodulators might eventually put out the fire, but they leave the patient standing in a burned-down house.
Okay. The damage is already done.
Yeah.
Right. Glucocorticoids cannot magically rebuild sclerotic, fibrotic mucosal tissue. They don't reverse the atrophy or restore that cellular microenvironment. That specific localized damage in the vaginal mucosa requires localized cellular repair.
So we have a biological environment that has essentially forgotten how to function because of the trauma, which forces us to look beyond just systemic suppression and into localized regenerative tools.
Exactly. You need something to rebuild the house, not just put out the fire.
When reviewing the notes from Dr. Trey's clinic in our stack, I really appreciated the grounded approach to demystifying exosomes because the marketing around regenerative medicine often way outpaces the clinical reality.
Oh, absolutely. It gets wild out there.
Yeah. She explicitly notes that exosomes are FDA regulated for safety and sourcing, but they are not FDA approved to cure specific diseases. And crucially, she emphasizes they are not stem cells.
That distinction separates the actual molecular biology from the science fiction. Exosomes are not stem cells, they are extracellular vesicles derived from them. They act entirely as cellular messengers.
So they don't differentiate into new tissue themselves.
No, not at all. They just deliver the message.
I was thinking about how to visualize this process for you. If your body's repair mechanism is a massive construction site, the stem cell is the general contractor. It arrives on site and has the potential to become different things or dictate broad actions.
That's a great way to look at it.
But the exosomes, they are the direct text messages and blueprints being sent from that contractor to the local workers, dictating exactly what to build, where to lay the biological brick, and what destructive processes to halt immediately.
And what's fascinating here is that this biological text message is carrying a very specific payload. We're looking at nano-sized vesicles, ranging from just 30 to 150 nanometers.
So unbelievably tiny.
Right, and they deliver a highly concentrated biological cargo of RNA, proteins, and enzymes directly into the target cells. Now, the sourcing of these vesicles varies depending on the clinical product.
Yeah, the research highlights a few primary sources. Adipose-derived mesenchymal stem cells are pretty common. Then there are umbilical cord-derived exosomes, which the protocols note are strictly harvested from uh, rigorously screened, healthy, full-term C-sections.
There's also some really fascinating data on botanical sources. Some products utilize exosomes derived from Rosa damascena, which is a type of rose purified using exo-CRT technology.
Wait, roses? That's wild.
Yeah, they use it to isolate the specific vesicles that promote tissue regeneration. But regardless of whether the origin is an AD, MSC, umbilical cord tissue, or a botanical source, the primary function remains the same.
They deliver an instruction manual to re-educate a cellular environment that has been entirely disrupted by chronic severe inflammation.
Exactly. But re-educating the environment is a monumental task when the CGVHD is actively driving inflammation. You can't just start laying down new cellular infrastructure if the donor immune cells are still, dropping bombs on the site.
Right, the sources suggest the exosomes have to establish a localized ceasefire first.
They do. And they initiate that ceasefire at a foundational molecular level. The research on mesenchymal stem cell-derived exosomes, or MSC exos, shows they deliver highly specific microRNAs directly into the local tissue environment.
The papers specifically track, MIR146A, LET7B, and MIR204. When I was reading through the pathway analysis, it seems like these microRNAs act like targeted missiles aimed directly at the NF-kappa B signaling pathway.
Spot on. The NF-kappa B pathway is basically a master regulator of inflammation. By silencing this specific pathway, those microRNAs drastically alter the behavior of the local macrophages.
Okay, remind me how the macrophages fit into this during a flare-up.
So during an active CGVHD flare-up, the macrophages dominating the tissue are locked in what we call an M1 phenotype.
Which is their angry, highly aggressive, pro-inflammatory state.
Exactly. It's destructive. But the microRNA payload delivered by the exosomes literally forces those macrophages to reprogram themselves on a genetic level.
Wow, really?
Yes. It induces a phenotypic shift from that destructive M1 state to the M2 phenotype, which is entirely anti-inflammatory and geared toward tissue repair and remodeling.
That's incredible. And while they are forcing that M1 to M2 shift, the exosomes are also upregulating regulatory T cells, or TREGs, in the local environment.
Right, and TREGs are the immune system's enforcers for tolerance.
So the exosomes are dropping into the vaginal tissue and broadcasting a localized override command to the aggressive donor immune cells, basically enforcing immune tolerance without requiring the patient to take a systemic drug that wipes out their entire remaining immune system.
It achieves targeted immunomodulation. You are silencing the specific inflammatory loop driving the CGVHD in that distinct mucosal layer, which paves the way for actual regeneration.
Okay, so the local immune environment is finally quieted down. The M1 macrophages have transitioned to M2s, the TREGs are keeping the peace, but we are still left with vaginal tissue that is incredibly thin, fragile, and entirely prone to dyspareunia.
The burn-down house, right?
Exactly. I was looking at the animal models in the research stack to understand how the exosomes force the tissue to physically rebuild. They used overrectomized rat models for this.
The overrectomizer rat model is crucial here because it perfectly simulates the severe baseline tissue weakness and lack of estrogen we see in these post-transplant CGVHG patients. It basically creates an environment of extreme mucosal atrophy.
Right. And in that specific study, the researchers delivered the exosomes vaginally, suspending them in a hyaluronic acid hydrogel. When they analyzed the tissue biopsies afterward, they tracked a massive, statistically significant spike in a biomarker called Ki-67.
Which is huge because Ki-67 acts as the ultimate biomarker for active cellular proliferation. Seeing that spike indicates that the basal layer of the vaginal epithelium, the foundational stratum, received the exosomal instruction to exit cellular rest and begin dividing rapidly.
So it prompted the tissue to physically stratify and thicken, restoring the structural cushion that the fibrosis had completely eroded.
Yes.
But I noticed the researchers weren't just satisfied with tissue thickness. They also tracked a significant upregulation in CD31. How does restoring the microvasculature actually relieve the friction pain?
Well, CD31 is a primary marker for angiogenesis, right? Building new blood vessels. In CGVHD, the aggressive inflammation often devascularizes the local tissue, just starving it of oxygen and nutrients.
It cuts off the supply lines.
Exactly. By upregulating CD31, the exosomes are commanding the local endothelial cells to build brand new blood vessel networks. You just cannot sustain a thickened, stratified mucosal layer without a robust vascular supply to feed it.
And as that vascular network rebuilds, the exosomes are simultaneously upregulating tight junction proteins, specifically ZO1 and occludin.
Right, which are essential for barrier function.
Exactly. By repairing those microscopic seals between the cells, they are restoring the tissue's protective barrier.
Yeah.
That drastically reduces the permeability of the mucosa, which is what drives so much of that hypersensitivity and pain upon contact.
You are basically structurally fortifying the wall, making it thicker, better fed by blood, and less permeable to irritants.
But structurally fortifying the wall doesn't solve the most debilitating symptom for the patient, right? I mean, we hear constantly about regenerative medicine boosting collagen for skin elasticity, but throwing collagen at this problem doesn't fix extreme vaginal dryness.
No, not at all.
Right. A thick wall without intrinsic moisture still results in severe dyspareunia. So I really dug into the sources to understand the lubrication mechanism. It turns out the exosomes are fundamentally altering the local intracellular chemistry.
The mechanism there is brilliant, honestly. The exosomal cargo increases the intracellular concentrations of two vital signaling molecules, cyclic AMP and cyclic GMP.
And when EMP and cGMP levels surge, it triggers the local epithelial cells to massively ramp up their production of lactic acid.
And lactic acid is the cornerstone of vaginal health. By driving up lactic acid production, the tissue's pH is aggressively lowered back to its optimal naturally acidic state.
Which is so important because that acidic shift is hostile to the pathogenic bacteria
Yeah.
that form those rigid inflammatory biofilms.
Exactly. But it creates the perfect biological niche for healthy lactobacillus to thrive and reestablish dominance.
It's all connected.
It really is. By engineering that pH shift, the exosomes are facilitating a complete microbiome restoration. It is that healthy, dominant lactobacillus flora that naturally restores the environment's intrinsic moisture and maintains the protective mucosal barrier.
So it is an ecosystem-wide correction, addressing the cellular division, the vascular supply, the burial proteins, and the microbiome all simultaneously.
The interconnectedness of those systems is staggering when you really look at it.
It is. But reading through the molecular biology is one thing. Applying it to a patient suffering from CGVHD is another. When you look at the clinical protocols for intimate exosome therapies, products like Aceplis IRLV or Exofemale, the guidelines for application are incredibly strict.
The clinical reality requires immense precision. The sources are definitive on this. Intimate exosomes for localized mucosal issues are never delivered via an intravenous drip. Intravenous administration for this specific pathology is functionally useless.
Right, because of the clearance rate. If you put these nanovesicles into systemic circulation, your liver, spleen, and lungs will clear them out long before they can accumulate in the vaginal mucosa in any therapeutic concentration.
Precisely. To be effective locally, the delivery mechanism has to ensure they stay trapped against the damaged tissue.
Which is exactly why the protocols mandate localized delivery. Typically, the exosomes are suspended in a hyaluronic acid hydrogel. The hydrogel acts as a highly biocompatible carrier matrix that conforms perfectly to the shape of the vaginal canal. It basically holds the exosome payload directly against the atrophic tissue.
And because hyaluronic acid naturally degrades over time, it allows for a sustained, slow release of the vesicles. This ensures maximum cellular uptake rather than having the product immediately flush from the environment.
I also saw in Dr. Sharon Lai's clinic notes that they frequently combine the topical exosome application with physical modalities, like microneedling or fractional lasers, specifically devices like the Morpheus 8V.
That combination therapy addresses the physical barrier created by the CGVHD itself. The tissue is frequently so sclerotic and heavily scarred that simply applying a topical hydrogel won't allow the exosomes to reach the basal layer where they're actually needed most.
You have to get the blueprints into the hands of the construction workers deep in the foundation.
Exactly. The microneedling creates controlled microchannels through that dense fibrotic scar tissue, allowing the exosome serum to physically penetrate down into the active cellular layers.
It forces the biological cargo past the damaged stratum corneum equivalent and directly into the viable tissue bed. But the implementation of these protocols comes with a deeply grounded warning in both the women's health clinic literature and Dr. Trey's letter.
Yes, the strict medical assessment requirement.
Right. When you are dealing with CGVHD patients, you are dealing with incredibly complex medical histories. The clinics emphasize that this is a targeted, highly advanced regenerative tool, not just some blanket wellness treatment.
Practitioners absolutely must perform a comprehensive assessment to rule out overlapping conditions. The dyspareunia could be complicated by hypertonic pelvic floor dysfunction, active fungal or bacterial infections, or structural issues that exosomes simply cannot fix.
It requires a practitioner who deeply understands the underlying mechanism of action. The microRNA pathways, the macrophage phenotypic shifts, the angiogenesis markers. It is a highly specific tool designed to correct cellular miscommunication and severe inflammatory tissue damage.
Right. It is not a guaranteed method to reverse natural menopause or cure stress urinary incontinence.
Exactly. When a clinic treats this therapy as a panacea rather than a targeted biological intervention, they do a massive disservice to the patient.
Completely agree.
So when you synthesize all of this source material, the implications for a CGVHD patient are profound. For someone who has survived a transplant only to find themselves suffering from debilitating intimate dryness and agonizing friction that makes daily life painful, we are finally moving beyond symptom management.
We're bypassing the limitations of systemic glucocorticoids that inevitably fail or cause toxicity.
Exosomes offer a biocompatible, entirely non-hormonal mechanism to command the local immune system to stand down. They deliver the precise microRNA payload required to force angry M1 macrophages into a healing M2 state.
Right.
And simultaneously, they deliver the blueprints that instruct the basal tissue to undergo active division, to rebuild its vascular networks, to reestablish its tight junctions, and to ramp up the lactic acid production necessary to restore its natural microbiome and moisture.
If we connect this to the bigger picture, it is a profound shift from merely suppressing the damage to actively engineering true tissue regeneration at the molecular level.
It fundamentally changes the diagnostic and treatment landscape for these patients.
It really does.
Yeah.
And if we extrapolate this mechanism out to the broader frontier of regenerative medicine, it raises a truly staggering possibility. We are currently relying on exosomes derived from donor stem cells or botanical sources to deliver these healing instructions.
Right, introducing foreign, albeit highly purified, cellular messengers to re-educate the tissue.
But if we now possess the technology to isolate and track these exact microRNA payloads, what is stopping us from eventually extracting a patient's own autologous exosomes and using CRISPR technology ex vivo to edit their specific microRNA cargo?
Oh, wow. You're talking about turning the patient's own cellular waste disposal system into a personalized, hyper-specific pharmacy.
Exactly. Imagine taking your own exosomes, editing them in a lab to carry a custom-coded set of instructions designed to eradicate your specific variant of an autoimmune disease and reimplanting them.
That is wild.
No donor cells, no risk of rejection, just your own biological messengers carrying a perfectly tailored cure for almost any localized inflammatory condition in the human body.
That completely redefines the boundaries of precision medicine. We are looking at a future where the instruction manual isn't just delivered, it's custom written for your exact genetic makeup. Thank you so much for joining us on this deep dive into the source material. We invite you to keep questioning the standard protocols, keep reading the underlying research, and keep exploring these incredible medical frontiers for yourself. Until next time.